Hi, I'm Denise Willis, one of the section editors for Respiratory Care. In this short video, I will be discussing the Editor's Choice paper from the August 2025 issue regarding empowering respiratory therapists to restrict nebulized 3% saline and N-Acetylcysteine during mechanical ventilation. The AARC Clinical Practice Guideline for Effectiveness of Pharmacologic Airway Clearance Therapy in Hospitalized Patients does not recommend routine use of inhaled mucoactive agents to promote airway clearance. Despite this recommendation, hypertonic saline and acetylcysteine are often used for this purpose without any clear evidence to support it. The authors of the current study had previously published a de-implementation process at their institution that allowed RTs to discontinue hypertonic saline and acetylcysteine when it was not in alignment with the clinical practice guideline. The policy was effective in reducing unnecessary therapy, but did not evaluate clinical outcomes, which was the aim of the current study. This was a retrospective review of 5 ICUs over a 3-year period that included adults who were intubated and mechanically ventilated for at least 48 hours. The primary outcome was ventilator-free days at day 28, and the secondary outcomes were ventilator and ICU days, length of stay, reintubation, and mortality. Data were analyzed in several ways, including comparison of pre- and post-implementation data, use of hypertonic and acetylcysteine versus no use of inhaled drugs with propensity matching, and then also a secondary analysis for hypertonic and acetylcysteine separately. Over 2,000 subjects were included in the study. There were some differences in baseline characteristics, with the post-implementation group being older, with more neurologic disorders and higher expected mortality. In this table, you can see the breakdown of subjects for those who did and did not receive the inhaled treatment and for propensity matching. Subjects in the post-implementation group, where use of inhaled therapy was reduced, had significantly more ventilator-free days at day 28 and overall reduced ventilator days, ICU days, and reintubations. In comparing subjects who did and did not receive treatment, those who were treated with hypertonic or acetylcysteine had significantly more ventilator-free days at day 28, overall reduced ventilator days, ICU and hospital length of stay, and reintubations. The results were similar with propensity matching, and there were no differences in mortality for any of the comparisons. Findings from this study suggest that the RT-driven policy to restrict use of hypertonic saline and acetylcysteine resulted in better clinical outcomes for ventilator days, length of stay, and reintubation. However, there are some limitations to keep in mind when interpreting the results, because this was a retrospective single-center study and not a randomized controlled trial. There may have been selection bias, as there were some differences in subject baseline characteristics, and the study did not evaluate the effect of hypertonic or acetylcysteine on mucus production. Authors concluded that not using these drugs for pharmacologic airway clearance in mechanically ventilated adults was not inferior to using them. The editorial by Ring highlights the common use of hypertonic saline and acetylcysteine in intubated patients despite the lack of evidence to support routine use. In principle, the mechanism of action for both of these drugs would seem to be a benefit, but that has yet to be proven for this patient population. Ring concludes that the study supports adherence to AARC clinical practice guidelines and emphasizes the role that RTs can have in influencing value-based care.